am Professor Patrick.
Professor?
Dr. Professor Patrick.
How's it going? Welcome to the Internal Medicine Review. This is going to be a case-based review of the Internal Medicine Shelf Exam, the portion of the Step 2 CK exam or COMLEX exam, and then for my PAs out there, the PANTS. We're going to go ahead and start things off with one of the longest and what I feel the most difficult section of Step 2 can be, which is cardiology. So what I want you to be able to accomplish after this review is characterize and manage acute coronary syndrome as well as the mimickers of chest pain that you'll see in the ED commonly. Be able to recognize, describe, and treat common tachy and Brady arrhythmias. Differentiate common cardiac murmurs. Diagnose and treat endocarditis and understand the causes and evidence-based treatments for heart failure. Manage different modalities of shock and evaluate and treat the arteries. So we'll start out with a STEMI, a ST segment elevation MI. So in these cases, you're often going to have somebody in their 50s to 60s with a history of some of the risk factors for coronary artery disease like diabetes, hypertension, hyperlipidemia, erectile dysfunction, and smoking history. And they're going to come in complaining of chest pain that radiates to the right arm and shoulder or jaw or chest pressure commonly. These symptoms are going to start usually when they're under activity or under emotional stress. On exam, they can usually be found to be hypertensive. It's a worrisome sign if they're hypotensive. They usually have an elevated pulse, elevated respirations. They appear pale, diaphoretic, and in acute distress. So your best first test that you want to do is an EKG. So what you're looking for is 2 millimeter ST segment elevations or a new left bundle branch block. So a wide, flat QRS. That's going to point you towards STEMI. So the EKG progression of a STEMI would be ST segment elevations almost immediately. You can get T wave inversions for 6 hours up to years after the event, and then the Q waves are going to be typical for a previous MI or a history of MI, and those will last forever. So once you've decided that this is sort of an acute coronary syndrome, the next best test after your EKG would be to get cardiac enzymes or CKMB or troponins. If they're elevated and there was no ST segment elevation, you can call this an NSTEMI, and you're going to want to check for these enzymes every 8 hours for 3 repeats to make sure that you're not missing an NSTEMI. So your CKMBs will rise a little bit slower than troponins, but they're going to peak at 24 hours and get back to normal limits within 3 days. So that's helpful if you've got somebody with a repeat MI that you're worried about, versus troponins will rise quicker, usually within 3 to 5 hours. They're going to peak within 1 to 2 days, but they won't come back to normal until almost 10 days after an event. So if you're looking at a repeat STEMI, you're going to want to order the CKMBs as well. So next up, we've got variations in atypical presentations. So not everyone knows how to have a heart attack the same way. So what if that patient had hypotension, tachycardia, clear lungs, JVD, and no pulsus paradoxus? So that's going to be more of a right ventricular infarct. We do not want to give these people nitroglycerin, beta blockers, or nitrites. So they are very preload dependent. So they need the fluid. So you're going to want to treat that with vigorous fluid resuscitation and taking them to the catheterization lab, like I said before. So what if that same patient had nausea, abdominal pain that was worse with exercise? So an inferior wall MI can have referred pain in the epigastric area due to the heart's placement on top of the diaphragm. So it can irritate the C3, C4, C5 nerve, the phrenic nerve, and it can give you pain that's sort of around the neck, around the belly area, and this is more common especially in older people and diabetics. So we've got a 56-year-old man who's homeless who comes to the ED with complaints of chest pain. He's agitated, he refuses to follow directions, his BP is extremely elevated, and his pulse is high. On cardiopulmonary exam, it's benign, but his pupils are dilated and his urine drug screen is positive for cocaine. So you can get cocaine-induced vasospasms. This is also an instance where we do not want to give beta blockers. So you're going to use benzodiazepines for the agitation and pain. Beta blockers would cause a blockade of the beta adrenergics, but they do not block the alpha adrenergics. So cocaine would continue to activate the alpha adrenergic and cause extremely high blood pressure. So our last case, we have a 45-year-old mother of 2 who's complaining of sudden onset shortness of breath, anxiety, and left arm numbness. She's been meaning to quit smoking and exercise and start a diet plan, but because she has a family history of cardiac disease, on exam she's hypertensive and anxious appearing. So women, especially those under 65, present with non-classical MI symptoms and thus have worse outcomes than male counterparts. So be sure to keep this on the differential, especially with women. There was a recent AMA morning rounds that showed that female physicians were able to diagnose women with MIs at a higher rate than men, so keep that in mind. So for the treatment of all of these MIs, we're going to want emergent reperfusion or go to the cath lab. Classically, they want door to balloon time at 90 minutes or less. And if you're not within a large major hospital system, if you're out in the boonies somewhere, thrombolytics are used within 24 hours, but they're best within 6 hours. So these contraindications we'll review again before thrombolytics with stroke therapy. But recent head trauma, a stroke, recent surgery, a dissecting aortic aneurysm, or active bleeding are all contraindications to use thrombolytics for an MI. So Mona-Bash is another treatment algorithm that you'll hear. So they start off with morphine, which is used both acutely for the pain, and it also is a minor vasodilator. So it will decrease preload and thus oxygen dependence of the heart. Next up is oxygen. Any increase in oxygen is thought to help oxygenate the tissue that is infarcted. Then nitroglycerin. So nitroglycerin is a powerful vasodilator, and this will decrease the preload and thus oxygen dependence of the heart. And then aspirin or clopidogrel. So these are used as platelet blocking agents. Usually 325 of aspirin is chewed up to increase its absorption rather quickly. And then clopidogrel is used after a stent placement. If it's a bare metal stent, you'll have 2 platelet blocking agents for at least a month. And then if it's a drug-eluting stent, 2 platelet blocking agents for at least a year. And then the BASH portion stands for beta blockers, which are used after an MI to decrease the remodeling of the heart. ACE inhibitors, or ARBs, are also used to decrease remodeling of the heart, lower afterload. And then short-acting nitrates, or statins for the S. Statins will decrease the risk of more plaque formation, and then short-acting nitrates are helpful if there's angina or other chest pain after they've had an acute event. And then the H is for heparin or low molecular weight heparin. So the Extract TIMI 25 and Essence trials showed that low molecular weight heparin or heparin after a acute MI decreased mortality. So one of the other treatment options that you have is a CABG, or a coronary artery bypass graft. So usually you would do a CABG if there is left main disease, if there's 3 vessel disease, if there's 2 vessel disease and they have diabetes, or if there's pain despite maximal medical treatment, or post-infarction angina. So this is reserved for those surgical candidates, and this is going to increase oxygenation by adding more vessels around the heart. So as always, you're going to want to quit smoking and manage their comorbidities aggressively, so treating hypertension, diabetes, hyperlipidemia, etc. So once we get into the NSTEMI versus unstable angina realm of ACS, we're going to have a 59-year-old man with hypertension, angina, a strong family history of coronary artery disease, and he comes to the ED with chest pain for the last 2 hours. He was on a morning walk, and his chest pain did not go away when he sat down. So this is a change in your angina, which is typically diagnostic for unstable angina. He's tried short-acting nitrates, and they did not relieve his symptoms either. On exam, he's slightly hypertensive, he's tachycardic, and his respirations are 20 per minute. He appears diaphoretic and anxious, and EKG shows no acute ST segment changes. So this doesn't meet the criteria for an ST segment elevation MI, but it's still within the realm of NSTEMI and unstable angina. So your next best step would be to do the cardiac enzymes. If they're elevated, you can diagnose an NSTEMI, or a subendocardial. The inner 1/3 to 1/2 of the wall tends to be a smaller MI, usually from a lagging plaque rupture. And if these cardiac enzymes are normal, we're going to call this unstable angina. So the TIMI risk, or the heart. So these scores are going to be used for mortality predictions and not management. So what you would want to do next is coronary angiography within 48 hours to determine the need for interventions. And then the Essence trial that I mentioned earlier, low molecular weight is better than full heparin. So in unstable angina and NSTEMIs, the risk of death, MI, and recurrent angina, or PCI, was lower with enoxaparin than heparin. So next, feeling stressed. We have a 55-year-old man with hypertension who presents to his PCP with 2 months of chest discomfort. So they start when he exercises or gets into an argument, and they last for 5 minutes before they go away. This is an important differentiating factor between angina and, the risk for unstable angina or NSTEMI is less than 20 minutes. So he's treated with propranolol and amlodipine for hypertension. On exam, his BP is normal, his pulse is fine, his respirations are 16, and EKG shows no ST segment changes. So your next best step is to do a stress test. But what kind? So you can do an exercise EKG. You would want to avoid beta blockers and calcium channel blockers before because they can interact with the EKG findings. And you can't do an EKG stress test if there's an old left bundle branch or baseline ST segment elevation or they're on digoxin. So you can try an exercise echo. And if they can't exercise, you can do chemical stress test instead, using dobutamine, dipyramidol, or adenosine. And then one last step that you can try is a myocardial perfusion imaging or MUGA scan that can increase the sensitivity of conventional stress tests. And before you would do one of these, you would want to avoid caffeine or theophylline. So these are going to be more radioactive scans where they can tell based on uptake of a radioactive substance where there is decreased perfusion in the heart. So with any of these measures, if you're going to see ST segment depressions, wall motion abnormalities, hypotension, or ventricular arrhythmias, these are all positive findings, and you would move on to coronary angiography and perform the workup just as you would for NSTEMI or unstable angina. So when you're looking at EKGs, location is key. So when you're looking at 1 AVL and then V5, V6, those are going to be your lateral leads. And those lateral leads usually correspond to the left coronary diagonal branch of the left anterior descending artery. So then your inferior leads are 2, 3, and AVF. And those are going to lead to the right coronary and or left circumflex artery, depending. And then your anterior or septal leads are going to be V1, 2, 3, and 4. So these are going to be more across the front of the heart, and they're your left anterior descending artery. So some common post-MI complications. So the most common cause of death within 24 hours after an MI is going to be arrhythmias, so VFib especially. Your new systolic murmur at the apex and shortness of breath. So this is going to be a papillary muscle rupture, usually 2 to 3 days after an MI. This is when the macrophages come in and start eating out the necrotic tissue, and that's when you're most at risk of having some of these ruptures, like a papillary muscle rupture. So if you have acute hypotension, pulsus paradoxus, that's going to be a free wall rupture, and this creates an acute tamponade-like scenario. And then if you've got an increased O2 from a right atria to right ventricle and a holosystolic murmur at Erb's point, this is going to be a ventricular septal rupture. So all three of those previous ones are going to be most common 3 to 5 days after an MI. So if you have a cold blue toe and a lacy rash, or livido reticularis, that's going to be cholesterol emboli syndrome. So look for eosinophilia and an acute kidney injury, and that can confirm the diagnosis. So if you have persistent ST segment elevations about a month after your MI, this can be a ventricular aneurysm. So that outpouching of wall is going to cause the ST segment elevations, and that's going to bring you a slightly increased risk of throwing a clot from that. So if you have palpitations and what's called Canon A waves or large JVD waveforms, that's going to be a 3rd degree heart block, and you're going to have to treat that with a pacer. We'll get more into heart blocks in a little bit. So 5 to 10 weeks later, if somebody has pleuritic chest pain and a low-grade temperature, this is Dressler syndrome. So this is an autoimmune pericarditis, and this is because you released a ton of troponins into the bloodstream, and your immune system actually recognizes that as someone to attack. So we can treat this with NSAIDs and aspirin. So next up, another deadly cause of chest pain is going to be aortic dissections. So this is commonly seen in question stems in truck drivers, and this is because they are restricted from taking certain medications while they're driving, anything that's going to cause the risk of hypotension, and that they would swerve off the road essentially. So we've got a truck driver that suddenly has stabbing and tearing chest pain that radiates to his back. He has a history of hypertension without treatment, positive VDRL or syphilis, and he smokes 2 packs per day. So his vital signs are very tachycardic, hypertensive in the right arm, and even more hypertensive in the left arm. So on exam, he's in distress, he's diaphoretic, and there's a new 3 out of 6 diastolic murmur in the right upper sternal border. We'll go into murmurs in a little while as well. So your next best step, if you're thinking aortic dissection, is to start therapy. So you want to lower his blood pressure, and you do not want to raise his heart rate. So IV beta blockers is going to be your first choice. So next step, you could look at a chest x-ray for a widened mediastinum. This is not very sensitive, but it can be specific. And then your confirmatory tests are usually CT angiogram and transesophageal echo. Those are your gold standards. The ultrasonography is increasingly used for rapid detection. So types and treatments. Type A is the ascending or proximal segment, and this is going to be need to treat with surgery to prevent the extension to an MI or a tamponade. And then type Bs are the only descending portion of the aneurysm, and you're going to treat these with medical therapy alone. So usually labetalol, nitroprusside to keep their BP less than 128. And you want to consider aortic dissection before giving thrombolytic medications for acute coronary syndrome. That can be a deadly mistake. So other causes of chest pain. So we've got a young woman who presents with no family history of cardiac disease, and she's got chest pain with the following symptoms. So usually you're not going to find a acute coronary syndrome cause of chest pain in somebody less than, say, 45-ish. So what would happen if she was moving boxes yesterday and she started a new exercise program at Orange Theory and she's had a cough? So on exam, her pain is reproduced with palpation on the sternum. So this is costochondritis. We're going to want to treat this with NSAIDs and supportive care. So she suddenly felt her surroundings spinning and closing in on her, and she has a history of anxiety treated with Buspar, and she's tachycardic and tachypnic with a normal blood pressure. So this is a panic attack, treated acutely with benzos, and then prophylactically, psychotherapy and SSRIs are your number one treatment here. So say she was a summer school teacher and she's getting over a URI 1 to 2 weeks ago. On exam, there is a new mild murmur. So she might have a myocarditis, maybe a Coxsackie virus that she caught at school. So check a screening echocardiogram for effusion and treat with supportive care. So last but not least, she states the pain occurs at rest, it's worse at night, and she has a history of migraine headaches. So this is more Prinzmetal angina. So you can diagnose this with ST segment elevations on a stress EKG, and you can confirm it with an ergotavine stimulation test. So we're going to treat this with calcium channel blockers or nitrates. So the last cause of chest pain that we'll go over today is pericarditis. So a 58-year-old with renal failure presents for chest pain. He missed his last 2 dialysis appointments because he couldn't find transportation. He states that the pain is worse on inspiration, it's better when leaning forward, and he has a history of URI 2 weeks ago and a renal transplant. So on exam, there's a friction rub heard. It sounds like Velcro almost. So your next best step is an EKG. So what we're looking for is diffuse ST segment elevations and PR depressions. And then echocardiogram can show an effusion or it could be normal. So some of these causes that, this patient had, almost all of them, post-viral, can cause a pericarditis, an MI, both acutely and Dressler syndrome 4 to 6 weeks later. Lupus can cause serositis all over the body, but commonly pericarditis. Uremia from missing his dialysis appointments, usually a uric acid or a BUN above 50 can cause this. Radiation and amyloidosis are also rare causes. So you can treat this with NSAIDs or colchicine. And don't forget the GI and pulmonary manifestations of chest pain like esophageal spasms, GERD, PE, pneumonia, Mallory-Weiss syndrome, etc. But this is it in terms of the cardiac section for chest pain. So next up, we're going to go over EKG interpretations and some buzzwords. So we're going to help find pattern recognition and illness scripts for a lot of the tachy and Brady arrhythmias. So first up, we've got sinus tachycardia. So usually it can be a younger person coming into the ED with fever, a change in mental status. He works at a construction site and he had cut himself incidentally earlier in the week but did not clean his wound. So vital signs are a little bit hypotensive, tachycardic, and a temperature of 38.8. So his skin is flushed and diaphoretic, and initial labs show leukocytosis with a left shift. So in sinus tachycardia, you're going to look for a regular, narrow pattern of QRS complexes with discernible P waves. So they look like camel humps. So anything can really cause sinus tachycardia, but think especially pain and anxiety, hypoxemia and hypovolemia. PE is the most common EKG finding for PE, but we'll learn some more specific ones. Sepsis, as in this case, and acidemia. So in order to treat sinus tachycardia, you have to fix the underlying cause. There is a drug that can be used. It's more commonly used in heart failure, but it is ivabradine. It's a sodium funny channel blocker, and this one can actually treat sinus tachycardia, but first you have to rule out all the other causes before you can treat it. Next up, we have SVT or Avnrt. So this is commonly in a younger woman. So we've got a young woman here presenting with dizziness and called 911 because her heart is going to beat out of her chest, or palpitations. She's had 2 episodes of this before that resolved spontaneously. So when she presented to the hospital, her vital signs were normotensive, a pulse usually above 150 but less than 170 to 200, and regular respirations. So her EKG is shown below. And what you're going to want to look for is narrow, regular pattern, and you cannot discern the P waves out of this. So most common cause of SVT is Avnrt, where there are 2 pathways, one fast and one slow, within the AV node, forming a reentrant loop, or a constant circle. This is usually initiated and terminated by PACs. And treatment options, you can try at first a vagal stimulation, so a carotid massage, and then you can try things like adenosine or verapamil. So next up, we've got Wolff Parkinson White. So we've got a young medical student who presents feeling palpitations and shortness of breath when studying for final exams, like we all have. And he stayed up all night, consumed multiple cups of coffee and energy drinks. So on presentation to the ED, his EKG is shown below. And what you want to look for is swooping R waves and a shortened PR interval. So pseudo-widened QRS. I call these like shark fins is what you want to see. So pathophysiologically, there's an accessory pathway from the atria to the ventricles called the bundle of Kent. And this causes early ventricular activation because the AV node does not slow conduction since you slid right by it. So if the unstable patient comes in, you want to synchronize cardiovert them. If you have a stable patient, procanamide is your best therapy. So you want to rule this out when you're thinking SVT. So make sure there are no swooped or shark fin QRS complexes. So long-term and definitive therapy is radiofrequency ablation. So in atrial flutter, we've usually got older patients. So a 67-year-old gentleman with episodic dizziness and shortness of breath is placed on a Holter monitor. On analysis, you read out the rhythm shown below. So classically, you want to look for a sawtooth pattern with a regular rate between 150 and 200. So you would look for those shark teeth instead of shark fins. It can usually be 2-to-1, 3-to-1 patterns between the QRS. And you want to think heart disease. Heart failure is the most common cause because you're stretching out those atria. Or rheumatic heart disease, CAD. COPD is another cause, and atrial septal defect has been associated with aflutter. So your treatment is going to be AV nodal blocking agents or ablation. And usually with ablation, it can return in 2 to 3 years or progress to AFib. So we've got multifocal atrial tachycardia next up. So this has a very classic illness script. So usually a older person presenting to the hospital for shortness of breath. They've got a very long smoking history and severe COPD requiring 5 liters of oxygen support. MedRec shows multiple beta agonist inhalers and theophylline. So vital signs show a normotensive, an elevated pulse, an irregular elevated pulse, and a normal temperature. So on exam, there's diffuse wheezes in all lung fields and prolonged expiration, increased AP diameter. So this is your classic illness script of someone with severe COPD. So there's also a loud P2 and a right heart heave. So EKGs show the rhythm shown below. So you're going to want to look for 3 morphologically distinct P waves in the same lead. So P waves or atrial beats starting from all different areas. So everywhere in the atria thinks that they are the AV node. So varying PR intervals because you're going to get contractions from various points in the atria. And then last, we've got atrial fibrillation. So this is the most common after sinus tachycardia. And we've got a 78-year-old woman with a history of diabetes, hypertension, and hypothyroidism, and an MI. She's had a syncopal episode at home. She lives alone, and she was unsure how long she was unconscious, but denies any tongue-biting, urinary incontinence, confusion upon awakening. So it seems like a non-seizure syncope episode. She also notices her left leg feels weak. She describes feeling her heart beat very fast at times, but she hasn't been seeking treatment. So a code stroke is called, and an EKG shows undulating baseline, or there's no real baseline where the wave starts at. There's no discernible P waves, so sometimes it can look like fibrillation or just random spikes. Other times you can't really even see it if it's fibbing really fine. And then irregular R to R intervals. So out of all of the irregular rhythms, AFib is going to be your most common, so you can pick that often. And then you're going to have to work through a bunch of causes for AFib. So heart disease, CAD, MIs, hypertension, regurg, pericarditis, rheumatic heart disease, pulmonary disease like a PE, and hyperthyroidism or hypothyroidism or a pheochromocytoma from endocrine. And then excessive alcohol intake is another one, so holiday heart syndrome. So the treatment is going to be AV nodal blocking agents. So rate control is better than rhythm control. If they're unstable, you can try synchronized cardioversion. And then the next step would be to do a CHADS VAS score to determine their anticoagulation needs, because AFib is going to increase your risk of stroke and embolic formation. So you would want to make sure anybody over 2 is on anticoagulation. So this woman here would definitely be in need of that. It sounds like she had a stroke. So ventricular tachycardia is now. So you're paged to the room of a 67-year-old who's post-op day 1 from a CABG post-STEMI. Like we said, post-op day 1s from MIs, or your most common cause of death is ventricular arrhythmias. He's unresponsive with this EKG rhythm. So we've got wide QRSs with a regular rhythm. So this is VTAC. So think CAD with MI is the most common cause, active ischemia, cardiomyopathies, congenital defects, or prolonged QT syndromes. So we're going to treat this with amiodarone or sotalol if they're hemodynamically stable. It sounds like this patient is not. So cardioversion if they're unstable, and ACLS if they're pulseless. So all of those with impaired ejection fractions and sustained VTAC need an ICT. And last up, we've got ventricular fibrillation. So we've got a 57-year-old patient on the general medicine floor is suddenly found to be unconscious. She's being treated for pneumonia with azithromycin, and her history includes amitriptyline for depression and fibromyalgia, quetiapine for bipolar depression, and ondansetron for nausea and methadone for pain. On further review of the telemetry reading, you notice that this rhythm. So you can see there is a wide-based irregular rhythm, and this one here is torsades, or twisting around the point. So if we notice, it gets bigger and smaller. So think ischemic heart disease, the most common cause for VFib, and then antiarrhythmic drugs that can prolong the QT intervals. So if you go through your anti-ABCDs and Os, or electrolyte abnormalities like hypokalemia and hypomagnesemia. So this patient in particular had a lot of the anti-ABCDEs and O. So your antibiotics, your antiarrhythmics, your antipsychotics, your antidepressants, your antiemetics, and then opioid medications can cause these abnormalities and cause a torsades de points. So usually it's a multiple hit hypothesis, so you have to be taking 2 to 3 or more. So your treatment is going to be ACLS algorithm, and if you've got somebody with a polymorphic VTAC like torsades, you're going to want to treat with magnesium. So next up, we've got ectopic beats. So we've got a case of a 23-year-old medical student with palpitations and tachycardia. So he's got an upcoming exam, and he was just on overnight call, so he consumed countless cups of coffee in an effort to study. So the EKG shows random segments of this type of rhythm here. So if you notice, there is an ectopic beat about 4 in. So there's no P wave before it. It's the opposite QRS, and then it's got a large repolarizing T wave. So what you want to look for a PAC is a premature QRS complex with normal P wave due to some pathomimetics, anxiety, caffeine, hypokalemia, or hypomagnesemia. So a PJC, or a junctional complex, is going to be a QRS with no preceding P wave. So these can be narrow or wide depending on where they come from. at the junction. And then PVCs, or ventricular contractions, are going to be broad-based QRS complexes, usually due to some pathomimetics like anxiety, caffeine, hypokalemia, and hypomagnesemia. This is also a sign of digoxin toxicity, and it can be a sign of ischemia. So if you've got 3 or more sustained PVCs, we would call that non-sustained VTAC. So for electrolytes and intoxications, we're going to start with our potassium. So our first case, we've got a 73-year-old renal failure patient presenting for chest pain and palpitations after missing their last 3 dialysis appointments. So if you look on EKG, those T waves are extremely tall and peaked forming. So the peaked T waves and a widened QRS complex, so the next EKG to the right shows sine wave forming, where you have up and down widened QRS, short QTC, and a prolonged PR. So these are all dangerous complications. Once you get to peak T waves, you can quickly move to the QRS forming sine waves, and then sudden cardiac death after that. So think crush injuries, burn injuries, and renal failure for extreme hyperkalemia. So your treatment algorithm is going to be IV calcium gluconate first. You can try D5 and insulin, which would increase reabsorption of potassium into the cells. You can try large doses of beta agonist. So for instance, an albuterol inhaler. And then for long-term treatment, you want to do K-exalate, furosemide, or dialysis to permanently remove the extra potassium from the body. So next up, we've got a 17-year-old with a history of anorexia and diuretic use, and he presents for inpatient rehabilitation program. So she is severely malnourished, and her labs and EKG shown below. So we've got somebody with a U-wave formation. So the T is diphasic, so it splits up and down, and there's a long QTC. So we want to think anything that's going to lose potassium. So diuretics are a big option, and then any type of GI upset. So if there's vomiting or diarrhea, those are the most common causes. So treatment, you're going to want to replenish your potassium. Oral is better than IV. And then you're also going to want to look at magnesium. If the magnesium is low, the potassium won't correct accordingly. So now we're going to move on into calcium. So we've got a 78-year-old man with metastatic lung and prostate cancer going to the ED with an altered mental status, oliguria, and abdominal pain. Labs show a calcium of 13.4, and EKG is shown below. So in hypercalcemia, look for a shortened QTC and then a notched prolonged QRS, as you can see above. And your first treatment option always is going to be fluids to dilute all the extra calcium. And then diuretics and bisphosphonates are going to be a long-term option to get rid of the extra calcium from the body and try and keep the calcium within the bones if it's somebody with metastatic cancer. So next up, we've got a 35-year-old with atypical depression who presents with seizures. His partner found a suicide note and an empty bottle of pills at home. So we're looking at a TCA overdose here. So Ilbutrin, and it's going to be a widened QRS due to the sodium channel blockade that TCAs can cause. So treatment here is going to be a bolus of sodium bicarb to overcome that competitive inhibition. So last up, we've got cardiac tamponade. So this is going to be a patient with a history of Marfan's disease, somebody with an ascending aortic dissection, and they're going to present with acute chest pain that feels like a knife radiating to their back. So on exam, there's unequal BPs in their arms and a pulse of 110. So suddenly they develop JVD, hypotension, and pulsus paradoxus. Heart sounds are distant, so this is Beck's triad, and then an EKG taken shows this below. So if you notice, if you look close, there are alternating QRS complex amplitudes, so electrical alternans as the heart swings forward in the pericardium or backwards in the pericardium. You're going to get larger and smaller electrical deflections on the EKG, and that's because the pericardium is filled with blood. So causes are aortic dissection and TB and metastatic tumors, and your treatment is going to be a pericardiocentesis. So you're going to take an ultrasound, guide it into the subxiphoid or fifth intercostal space, and you want to rapidly drain the blood so the heart can fill up. It can regain that preload and start pumping out to the body again. So now moving on to the Brady Arrhythmias, sinus bradycardia. So a 22-year-old marathon runner presents for her NCAA pre-participation physical. A screening EKG shows this rhythm. So if you've got P waves that are less than 60 beats per minute, think of sinus bradycardia. So it can be normal finding in athletes because their hearts are so conditioned, or it can be due to ischemia, increased vagal tone, antiarrhythmic drugs like AV nodal blocking agents, think of a calcium channel blocker overdose or a beta blocker overdose, or a brainstem herniation, so Cushing's syndrome. So we can treat this with atropine to speed up the heart, or a cardiac pacemaker, depending on how stable the patient is. Moving into heart blocks. So we've got a 23-year-old medical student from New Jersey who has complaints of palpitations and joint pain following a hiking trip. He's unsure if there was a rash or tick bite history. So your heart blocks, first degree AV block is just going to be a prolonged PR interval with no dropped beats. So anything that's longer than 0.2 seconds between your P and your QRS is going to be first degree. So second degree heart block can be divided into two different treatments. So we've got Mobitz type 1 or Mobitz type 2, Wenckebach. So type 1 is going to be progressive prolongation of the PR interval followed by a drop beat. So it'll get longer drop. Now you've got a Wenckebach. So treatment usually doesn't require anything unless there's unexplained syndromes. Moving into the Mobitz type 2 and third degree heart block. So we'll have someone presenting usually for syncope and palpitations, and a lot of the times they've got a coronary history, so CHF and MI. And then vital signs are going to be a little bit bradycardia and a regular rate. So on exam, there's irregular jugular venous waveforms, or Canon A waves, like I had mentioned earlier. So this is a patient with a third degree or complete heart block. So look for regular P to P intervals and regular R to R intervals. So they're marching to their own beats. A lot of the times you'll lose a P interval underneath the QRS, and the pathophysiology of these Canon A waves is actually going to be the atria contracting at the same time as the ventricles are contracting. So you cannot pump the blood into the ventricles, so the blood goes back up, and that's why you'll see the waves in the jugular venous. So our second degree heart block, or Mobitz type 2, we're looking for prolonged PR intervals with dropped beats. So these are the same distance apart, they're not getting longer. And type 2 is more dangerous than type 1 because it'll likely lead to type 3. So with either of these, we're going to want to treat with a pacemaker implantation. And our last Brady arrhythmia, we've got sick sinus syndrome. So we've got usually a very elderly person presenting with periodic presyncope, dizziness, confusion, fatigue, and palpitations. They've had no cardiac history and they only take a multivitamin. So during your interview, her pulse ranges from 40 to 120 beats per minute. So sick sinus syndrome is kind of like your catch-all at the end of these arrhythmia sections. If you've got alternating bradycardia, tachycardia, and even sinus arrest, this can all be caused by sick sinus. And it's often idiopathic in the elderly. Sometimes it can be caused by sarcoidosis, cardiac sarcoidosis, or ischemia. And with these, you're going to need to treat with a pacemaker as well. So now moving on into the murmur section, we're going to start with the systolic murmurs, or MIAS and TIPS. So MIAS stands for mitral insufficiency or regurg aortic stenosis, and those are both systolic. And then the TIPS stands for tricuspid insufficiency or regurg pulmonic stenosis, and those are both systolic again. So you can use this helpful mnemonic to remember which ones are systolic and diastolic. So we've got a 64-year-old patient with angina, dizziness, syncope, and shortness of breath. On exam, their blood pressure is elevated, and there's a 4 out of 6 crescendo decrescendo systolic murmur heard in the right sternal border, radiating to the carotids, that is louder when squatting and softer with Valsalva. So their pulse has a delayed upstroke. So this is a classic finding for aortic stenosis. So you've got a dystrophic calcification in the elderly, and then commonly you can see congenital bicuspid aorta in somebody with Turner syndrome or a familial inheritance of it. So let's go through this exam one more time. So the 4 out of 6 crescendo decrescendo murmur that's heard in the right sternal border. So the right sternal border is the aortic auscultation point, and then it's a systolic murmur. So if you follow your MIAS, that should lead you to aortic stenosis. And then the maneuvers that you can do here, louder when squatting is going to decrease the amount of blood that goes through, so increase the murmur. And then softer with Valsalva, which is once again going to decrease the preload. And then when there's less blood going through, you're going to hear the murmur less. So next up, we've got a 21-year-old college basketball athlete following a syncopal episode suffered in practice. So she had previously felt lightheaded but attributed this to poor conditioning. Her family history is relevant for her father passing away at 34 from unknown causes. On exam, there's a 3 out of 6 systolic ejection murmur that increases with Valsalva and decreases with squatting and hand grip. So this is going to be more of a hypertrophic obstructive coronary or cardiomyopathy, a HOCM case. This is an autosomal dominant inherited condition of beta-2 macroglobulin, and we can treat this with beta blockers to prevent the remodeling on the heart and prevent the tachycardia, or you can implant an ICD or use ethanol ablation if that's unsuccessful. So going over the exam one more time for this one, it is also in the aortic auscultation point, and it's 3 out of 6. But if you notice, it increases with Valsalva and decreases with squatting, and that's because this is an obstructive myopathy. So if you don't have the preload, aka you don't have increased preload with Valsalva, then you're going to increase the amount of obstruction as you're trying to leave. So the idea is to increase preload and to lower the heart rate, and that will decrease the symptoms in these patients. So continuing on with systolic murmurs, we've got a 64-year-old woman with decreasing exercise tolerance and swollen ankles. She had a history of a systolic murmur leading to left atrial enlargement and a new diagnosis of AFib. On exam, there's 4 out of 6 holosystolic murmur in the 5th intercostal space at the midclavicular line. So that's going to be your mitral auscultation point, and this radiates to the axilla. So this is a mitral regurg. If you do the myosin tips, MI is mitral insufficiency. And this is going to be due to myxomatous degeneration or papillary muscle ruptures commonly. So this can be in elderly individuals, this can be post-MI, or this can be post-rheumatic fever. So now we've got a 34-year-old woman presenting for palpitations and chest pain. She insists she's having a heart attack and demands to be treated. On exam, she's visibly anxious, and a click is auscultated during mid-systole with a faint 1 out of 6 murmur at the cardiac apex. So this is also in the mitral area. There's a click and then a faint murmur. So this is during systole. So this is the mitral valve again, and this is mitral valve prolapse. And mitral valve prolapse can be associated with panic attacks and chest pain, and these people are treated with beta blockers. Moving on to diastolic murmurs, you can do Ames and Pitts to remember your diastolic murmurs, or just know that it's the opposite of the myosin tips. So we've got a 14-year-old immigrant from sub-Saharan Africa presenting for decreased exercise tolerance. She has a history of repeated infections with joint pain, subcutaneous nodules, rashes, and swaying movements. On exam, a systolic snap followed by a 4 out of 6 rumbling diastolic murmur is heard in the 5th intercostal space at the midclavicular that radiates to the axilla. So this is once again in the mitral auscultation point, but this is during diastole, so we can assume this is mitral stenosis. And this particular instance is caused by rheumatic heart disease, so the repeated infections with joint pain, subcutaneous nodules, rashes, and swaying movements, or Jones criteria, we'll get to later. So this can lead to pulmonary hypertension, left atrial enlargement, and AFib, and the treatment for this is going to be beta blockers and diuretics for minor symptoms, or balloon valvuloplasty for severe symptoms. Next up, we've got a 53-year-old with Marfan's disease presenting for fatigue, palpitations, and head bombing. On exam, the blood pressure is elevated, and if you notice, there's a widened pulse pressure, so 102 millimeters of mercury between the systolic and diastolic. Pulses are elevated, and a blowing diastolic murmur is heard at the left upper sternal border. So left upper sternal border is pulmonic location, but since this is a regurgitant murmur, we can actually hear it better in the pulmonic location than the aortic. So this is aortic regurg, caused by usually tertiary syphilis, a congenital or a collagen vascular disease, a dissection, or endocarditis, and we can treat this with afterload reduction and valve replacement using a TAVR. Some more diastolic murmurs. We've got a 48-year-old presenting with flushing, diarrhea, and shortness of breath. On exam, there's a soft diastolic rumble over the left sternal border that increases with inspiration. So a CT scan shows multiple areas of concern in the colon and liver. So this is someone with carcinoid syndrome that's causing disease of the tricuspid valve. And then you can also get this with rheumatic fever or SLE. So an interesting point here is that the murmur increases with inspiration, and that's because you can increase the amount of blood that flows through the right side of the heart. With inspiration, you decrease the pressure in the thoracic cavity, and you can increase preload. So that's called Carvalho's sign, is increasing right-sided murmurs with inspiration. So lastly, we've got a 57-year-old man with fatigue and multiple syncopal episodes without exertion. He does not have confusion following these episodes, and he denies any palpitations, hypertension, or dehydration. On exam, there's a plop with a changing murmur. So this is a myxomal. This is an atrial myxoma. It's a benign pedunculated mass that rarely causes valvular damage, and that's because this mass randomly plops into the atria and cuts off blood flow, causing syncope. So we can treat this with a surgical excision. So now we're going to talk about some congenital lesions in adulthood. We've got a lot more on congenital lesions in the cardiac section of the PEDS review, but these are going to be congenital lesions that cause issues in adults so that you can see them on the internal medicine portion of the exam. So we have an 18-year-old Army recruit that complains of pain in his legs when he runs. On exam, his pulse is 76, his blood pressure is elevated at 165/90, and his radial pulses are +4. His dorsalis pedis pulses are +1. So this is a coarctation of the aorta. It's associated with Turner syndrome, Face syndrome, or bicuspid aortic valve. And this is going to be increasing the amount of blood that you get in the upper section of the thoracic root, and then decreasing the amount of blood that you get into the descending aortic aneurysm. So classically, they will show an X-ray, and you can see the 3-sign or rib notching like I've shown here. And next up, we've got a 29-year-old that's found to be cyanotic and in distress. She was known to have a congenital heart murmur characterized by a fixed split of S2. So that buzzword there, fixed split of S2, is an atrial septal defect. It's associated with Down syndrome. And then long-term, you can get Eisenmenger syndrome or reversal of the shunt. So eventually, there's enough pulmonary hypertension. This reversal of the shunt can take it from a left to right shunt to a right to left shunt or a cyanotic shunt. Next up, we've got acute infective endocarditis. So this is commonly a younger person that has a history of IV drug use. So they can present with a cough, recurrent fevers, and painful nodules on their hands, or Osler's nodes. So their vital signs are usually increased temperature, tachycardic, a little bit hypotensive, and increased respirations. On exam, there's a new murmur, so a systolic murmur that's best heard in the left sternal border. So as we just learned, that's going to be a tricuspid stenosis murmur. So your next best step is to do blood cultures, followed by broad spectrum IV antibiotics until the culture is known. So with IV drug use, you should think staph, Pseudomonas, and Candida infections. And then in order to diagnose infective endocarditis, you can use Duke's criteria. So the major criteria are sustained bacteremia or endocardial involvement, either by an echo or evidence of a new murmur. And then the minor criteria are an abnormal valve, so history of some type of valvular defect, fever, vascular phenomenon like septic emboli, immune phenomenon like the Osler's nodes, or blood cultures or echo that is not meeting major requirements. So changes that are not quite sustained bacteremia or a new echo plaque. So now subacute infective endocarditis. These are usually older individuals with a history of valvular defect like a prostatic heart valve. So this patient is feeling feverish 4 weeks after a dental cleaning. They also had strange marks on his hands and fingernails. So vital signs are temperature of 38.2, pulse of 89, normotensive, and respirations of 20. So there's a 2 out of 6 murmur on exam. We don't know what his baseline is. So causes, think strep viridans, Enterococcus or Hay-Sec organisms, so Haemophilus, Actinobacillus, Cardiobacterium, Echinonella, and Kingella. So you can try prophylaxis with penicillins or cephalosporins, clindamycin or macrolides if they're allergic, only if they have a prostatic heart valve, previous endocarditis, or an unrepaired cyanotic heart valve. And then you can also get non-bacterial endocarditis or merantic, which is associated with cancers and hypercoagulable states, and Lieben-Sachs endocarditis, which is associated with SLE. So here's some of the media files associated with endocarditis. So the Janway lesions are going to be pigmented lesions on the palms of the hands, and they're non-painful. And then Roth spots are going to be fluffy plaques in the eyes. And then your vascular phenomenon are going to be Osler's nodes, or painful swellings on the palms and fingers of the hands, and then splinter hemorrhages in the fingernails. Now we're going to move on into congestive heart failure. So the classic illness script for someone with CHF is going to be an older man who's got cough and worsening shortness of breath for 3 years. He now wakes up at night short of breath. He doesn't have any chest pain. On exam, there's a pulse of 76, blood pressure of 110/80, and he has rales in all lung fields. His PMI is displaced laterally, and his liver span is increasing to 14 centimeters. So there's pitting edema to the knees. Jugular venous distension is noted to the angle of the jaw. And then echocardiogram shows a decreased ejection fraction with 30%, with concentric increase in left ventricular wall size. The valves appear normal. So we can divide up our heart failures into HFrEF and HFpEF. So HFrEF is heart failure with reduced ejection fraction. So this is decreased ejection fraction less than 55%. It's otherwise known as systolic heart failure. And then HFpEF is heart failure with preserved ejection fraction. This is a normal ejection fraction, or otherwise known as diastolic heart failure. So some of the different causes of HFpEF versus HFrEF. HFrEF is far more common. It's usually caused by post-ischemic cardiomyopathy or long-term hypertension and valvular disease. It can be also induced by drugs like trastuzumab or daunorubicin. So these are common chemotherapeutic drugs. Drugs of abuse like alcohol, cocaine, and methamphetamines. And then bugs like myocarditis, like Chagas disease, and hemochromatosis. So HFpEF is going to be caused by amyloidosis, like AA, multiple myeloma, or SA, and rheumatologic. And then high output cardiac failure is actually slightly different than HFpEF or HFrEF, and these are usually caused by anemia, pregnancy, hyperthyroidism, fistulas, acute beriberi syndrome, Paget's disease, or some type of valvular defect. So in order to diagnose CHF and to treat it, the next best step is going to be a chest x-ray showing cardiomegaly, and you can also see curly B lines from pleural effusions. Next up, you would want to try an echocardiogram. This is going to be your gold standard to show the ejection fraction, to test the hypertrophy and look for valvular disease, which you have to rule out. Some laboratory studies that you can also do. You can try a CMP to look for hyponatremia. It's a poor prognostic factor. And then you can also order a BNP, or a brain natriuretic peptide, which is very sensitive but not specific for heart failure. Some contraindications in heart failure, medication changes you want to make: not to use metformin, not to use calcium channel blockers, not to use NSAIDs or thiaglitazones. So some treatment options that you have showing mortality benefits in heart failure. So ACE inhibitors, or ARBs, was shown in the SOLVE trial and consensus trial to prevent remodeling by aldosterone. And then in the Paradigm HF trial recently, sacubitril and valsartan showed an extra 20% mortality benefit over just an ACE and ARB inhibitor. So sacubitril is a natriuretic peptide inhibitor, so it stops the breakdown of BNP, which kind of reverses the pathway of angiotensin. So the RAS pathway versus the natriuretic peptide pathway. Beta blockers are also useful to prevent remodeling from epinephrine and norepinephrine, and that was shown in the BEST trial. And then ivabradine, in addition to beta blockers, in the SHIFT trial, shows that if you lower the heart rate of somebody into the 70s, with ivabradine, you can actually show decreased hospitalization rate from exacerbations. So next up, we've got spironolactone, which improves survival in New York Heart Association class 3 and 4, and this was the RAIL study. So this is a potassium-sparing diuretic. And then you've got hydralazine and isosorbide dinitrate, which is proven in African American people as a extra benefit that you can do. And then when your ejection fraction drops less than 35%, you can implant an ICD to prevent the risk of spontaneous ventricular arrhythmias. So furosemide, digoxin, and dobutamine, those are going to decrease the water and sodium restriction and improve their symptoms, but it does not change their survival. So we're going to move into shock now. So we've got a 96-year-old woman presenting from a nursing home for lethargy and change in mental status. She's got a history of MI, CHF, and a prior stroke. Her vital signs are temperature of 36.5, BP of 90/56, pulse of 121, and respirations of 24. She appears flushed. So your next best step is to stabilize the patient and determine the cause of shock. So CABs, your cardiac, airway, and breathing are first. You want to establish access. So 2 large bore IVs with a fluid bolus, and then you want to think about central lines and arterial lines to give pressor support. Next up, you want to order your labs, usually a CBC, CMP, PTs, ABGs, and blood cultures, and do any tests like ECGs or chest x-rays to determine the cause. So when you're looking at shock, there's a couple of hemodynamic principles that you want to keep in mind to determine the cause. So you want to look at cardiac output, you want to look at systemic vascular resistance, and you want to look at pulmonary capillary wedge pressure. So that's how you can differentiate these. So this patient seems to be in more of a septic or distributive shock. So they have an increased cardiac output, their pulse will go up, they've got decreased systemic vascular resistance, so their blood pressure drops, and then their pulmonary capillary wedge pressure will also drop. So some causes and treatments. If this was a cardiogenic shock, it can be usually caused by MIs, tamponade, CHF, tension pneumothorax, PEs, and the features are going to be JVD is what you want to look for. So there's preload backing up before it can get into the heart. They'll be pale and cool extremities, and they might show rails on exam. So to diagnose this, you want to look at an echo or an EKG, and to treat this, you would use dobutamine or an intra-aortic balloon pump or an LVAD, and you would not want to give excess fluids to these people. So if there is a hypovolemic shock, causes like hemorrhage, dehydration, and burns, you're going to have dry mucous membranes. This is what to look for in exam if you see that buzzword. So to diagnose this, you would do a Swan-Ganz with a low pulmonary capillary wedge pressure. And you can treat this with aggressive crystalloids and blood products. If you've got septic shock, causes like pneumonia, pyelonephritis, meningitis, cholangitis, any type of infection, itis. So you'll see somebody who's febrile or hypothermic, and they've got warm skin and tachycardia. So you can diagnose it with blood cultures, but you're going to want to start treatment almost immediately with broad spectrum antibiotics, fluids, and pressor support. And then last, the least most common cause of shock is definitely neurologic, or this is sympathetic denervation. So causes like a spinal cord injury, a head injury, or anesthesia. So you're going to have warm skin and hypotension and bradycardia. So you can use judicious fluids and vasopressor support. So they lost the sympathetic nervous system activation to keep blood and to keep the tone in the vasculature. So now moving out to the arteries, we've got peripheral arterial disease. So this is commonly in an older person with a history of diabetes and smoking, and they commonly present with calf pain. So they used to get the pain when they were walking uphill to get as male, and it would resolve. But now if you get calf pain when watching TV or sleeping, and you improve that pain when you lay the leg over the end of the bed or couch, so that's a worrisome sign. On exam, there's decreased hair found in the leg with absent dorsal pedis and posterior tibial pulses, and there's a quarter-sized ulcer seen on the toe. So next best step here when you're looking for peripheral arterial disease is definitely an ABI, an ankle to brachial index. Anything less than 0.7 is going to be diagnostic. And your arteriography is your gold standard, but that's an invasive test, so they typically do just an ABI and ultrasounds now. Treatment is going to be controlling the risk factors and stopping smoking. So stopping smoking is the number one predictive factor here. Exercise therapy has been shown that it can improve, so they would walk until they get the pain, stop and rest, and then continue to walk when the pain goes away and see how they can push the blood flow to the leg. Aspirin and silastazole are also helpful therapies to prevent any clot formation, especially given that they'll have a history of CAD. They should be on aspirin anyways. So severe disease may require surgical intervention, so a bypass or an amputation. So location, usually a femoral to popliteal, you get calf claudication, and aortic to iliac, you would get like buttock and hip claudication. So depending on where the blockage is, you can see different symptoms. So now we've got renal vascular hypertension. So these are usually either younger women or older men, and they'll present for health screening, and they'll have an elevated BP. This young woman with an elevated BP has a healthy diet, exercises, no family history. On exam, you might be able to hear a bruit in the right or left upper abdomen. So your next best step here is an abdominal duplex ultrasound. So renal arteriography and MRI are gold standard, but its contrast is nephrotoxic, and the problem is less blood flow to the kidney, so it's not a good idea. So some of the causes are fibromuscular dysplasia. This is usually a young woman with sudden onset or new hypertension, or atherosclerosis in somebody who's an older man with smoking and hyperlipidemia. And both of these are usually hard to treat hypertension, requiring 3 or more drugs. So try and think about this if you've got resistant hypertension with 3 or more drugs. Treatment, you can do conservative medical therapy with an ACE or an ARB, or revascularization with a percutaneous transluminal renal angiography. Other causes of secondary hypertension would be a 58-year-old man with primary care office following up on his blood pressure. He's lost weight, he eats a low-sodium diet, but his blood pressure is persistently elevated. His wife sleeps in a different room because he snores loudly, and he takes frequent naps during the day, and he sometimes wakes up with a headache. On exam, his neck size is 18, and he has a Mallampati score of 4, where you cannot even see the uvula because the tongue and palate is so close together. So your next best step would be a polysomnography test. So causes of your secondary hypertension include renovascular hypertension, which we just covered, obstructive sleep apnea, which is the case in this vignette, Conn syndrome or elevated aldosterone output, Cushing syndrome or elevated glucocorticoid output, pheochromocytomas, which are going to be elevated adrenergic, and then hyperthyroidism, OCPs, which can elevate blood pressure, usually 10 to 15 at the maximum, alcohol, nicotine, or white coat hypertension. So with all of these, the treatment is going to be finding the underlying causes and treating that. As always, you want to quit smoking and decrease alcohol intake. If there's an option on the test, you can always select those. So in this case in particular, we need CPAP or BiPAP whenever they're sleeping, and weight loss. Next up, we've got abdominal aortic aneurysms. So we have a 66-year-old veteran with a history of hypertension, diabetes, hyperlipidemia, and a 50-pack year smoking history, presenting with sudden onset back pain. He describes the pain as throbbing, with a sense of fullness in his abdomen and dizziness when he stands up. Vital signs are hypotensive with an elevated pulse. On exam, there's ecchymoses on the flank and around the umbilicus. So your next best step here would be a fast exam and on to emergent surgery. So with abdominal aortic aneurysms, it is recommended by the USPSTF to screen any man 65 to 75 with any smoking history. So it doesn't matter if they smoke for 5 years in college, to get a one-time ultrasound screening to determine the size of their abdominal aorta. Anyone who is greater than 5 centimeters can have follow-up with ultrasound or CT scan to track the progress. If it's greater than 5 centimeter in men, 4.5 in women, or it progresses to greater than 1 centimeter per year, usually endovascular repair is recommended before any type of collapse like this where there's a high morbidity and mortality. Now we've got acute arterial occlusion. So in this case, we've got a 65-year-old woman with a history of hypertension, hyperlipidemia, and mitral stenosis with sudden onset leg pain. So she had felt palpitations earlier that week but brushed it off. On exam, you notice the leg is pale, cold, and without palpable pulses. So the patient is unable to move the leg or feel. So your next best step is arteriography to locate the clot. So these are the 6 P's of an acute arterial occlusion: pain, pallor, polar or cold, paresthesias, paralysis, and pulselessness. So the last one is very difficult to treat once you get to this point. So you want to start with a heparin drip or a surgical thrombectomy within 6 hours, or else they might lose the limb. And then you want to monitor for compartment syndrome and reperfusion injury. So now we've got a 71-year-old man with a blue toe and a molting rash on his left leg 1 day after a PCI. He's had stomach pain and renal function decreases as well. So this is cholesterol emboli syndrome, like I mentioned before, and the rash is called livedo reticularis, or a molting lace-like rash that's blue and pale. And this is usually due to tissue ischemia from cholesterol emboli that get lodged within the kidney and usually extremities. Now moving into DVTs, we've got a 38-year-old woman with a history of lupus and recurrent miscarriages that has calf pain after returning from a business trip in China. She states that the pain is worse when walking, her vital signs are normal, and on exam there's pain with dorsiflexion and a palpable cord. So the pain with dorsiflexion is Hohmann's sign, and the palpable cord can sometimes be felt with the DVT in the lower extremities. The next best step would be to do a Doppler ultrasound. So venogram is gold standard but invasive. You can also do a D-dimer. It's very sensitive but not very specific. And your treatment is going to be a heparin bridging to warfarin or a DOAC-NOAC for 3 to 6 months if it's a first-time offense, lifetime if it's their second offense or more. Prophylaxis with high risk and post-surgical patients with compression stocking, early ambulation, SCDs, and low molecular weight heparin in the hospital to prevent these. And complications that you worry about are PE and post-thrombotic syndrome. Rarely you can get phlegmasma, Sorelia, dolens. Now we're going to move on to the vasculitides, all the different vasculitis problems that can affect you. So these are just a common illness script of what to expect. So if you had a 69-year-old woman with new onset headache, pain is one-sided around the temple and worsens with eating or jaw claudication. She feels feverish, weak, and she's lost 5 pounds. So this is a classic giant cell temporal arteritis. It's on a spectrum with polymyalgia rheumatica. You can diagnose it with a high ESR and a temporal artery biopsy, and you want to treat it with prednisone, usually 1 milligram per kilogram. And you treat this before the results because the most worrisome cause here is blindness, so optic neuritis and amaurosis fugax from optic compression. And then next up, we've got a younger woman, usually an Asian, who presents with intermittent arm pain and numbness. They can have fevers, weight loss, malaise. Vital signs are decreased blood pressure in one arm. So this is Takayatsu's arteritis. You can diagnose with a venogram, and you can treat this with prednisone or surgery. So now we've got a 38-year-old with hepatitis B and HIV who presents with fever, weight loss, abdominal pain, and a molted lacy rash. So this is polyarteritis nodosa, PAN. So you can do an ESR and a P-ANCA for this. You can diagnose it with biopsy definitively, and you want to treat with steroids and cyclophosphamide. So now we've got a young smoker with cold fingers that have ulcerations at the tip. And he says when he goes into the refrigerator section at the grocery store, his fingers change color and are painful, or Raynaud syndrome. So this is Berger's disease or thromboangiitis obliterans. So this is commonly in young people that smoke, and if they quit smoking, their fingers won't fall off. So good news there. And lastly, we've got a 58-year-old Middle Eastern man who presents with painful ulcers on his genitals, as well as joint pain and vision loss. And this is Behçet syndrome. You can get ulcers of any mucosal surface, and you want to diagnose this with biopsy and treat it aggressively with steroids. So that marks the end of the cardiac chapter. Next up, we've got pulmonary.
I am Professor Patrick.
Professor?
Dr. Professor Patrick.